All right, who'd like to go first today? Seth, you want to start us out?
Sure. Let's see here. So this is um, something we've seen before, but what I kind of think is interesting about this uh, is seeing how this has changed over a while. So this is a guy who has this diffuse myocardial calcification. Uh, a couple people have shown this. I showed a case a couple of years ago. That person also very nicely had metastatic pulmonary ossification or calcification, sorry, as well. And this calcium deposition you get in. There's different etiologies, supposed. The cases I've all seen have been associated with renal failure, either acute or chronic. But what's kind of interesting about this case is we had an old study from 2012, or I'm sorry, 2002, and you can see here's his renal transplant. And if I showed them side by side, unfortunately I didn't do it, you would notice that the calcification has actually gotten better since 2002. And looking up his history, his renal function has kind of improved since this was initially done in 2002. So I don't know the relationship between improving calcium homeostasis and improve if people have seen improvement in the metastatic calcification we've seen in the lungs, but it would apparently appear that the myocardial abnormality could get better. I don't know if anyone else has seen that or has any logical explanation about how the calcium would resorb, but here is it. So this is about the same level on the two, and it just looks, again, it just looks better.
So
So,
did he have heart failure with all of this? I came in
no,
late.
no. So all the cases I've seen, they have normal EFs.
Okay. So this
Normal?
wasn't post resuscitation
No, no.
myocardial. Okay.
Yeah, no myocardial injury. We've seen this. I now have four cases actually, where they're all associated with acute or basically acute renal failure. And I don't know if this kid or when he was a kid had some episode of acute renal failure, but the cases I have are all patients had acute renal failure when they developed this, or have chronic renal failure when it's found, and it's assumed to be secondary to some degree to renal failure. That's been the kind of constant for the cases I've seen. And even though it's associated with, they talk about myocardial necrosis, the EFs are normal. In all the cases I've seen, they've done echoes and the EFs are normal. And his EF is normal as well.
Hmm.
I don't understand it personally, how with this much calcium deposition you would have a normal ejection fraction, but that's what I've seen with the cases. I don't know if anyone else has anything to comment. I know it's been called a stone heart. I think some people wrote a case report from MGH, or maybe even Travis wrote it many years ago.
Yeah, I think some instances have been reported in the context of not just acute renal failure, but sepsis and other things where the calcium developed over a short period of time. So
Yes.
that also has been described.
Yes, and I have a case where someone was septic, and the question is the sepsis or is it the renal failure? Someone was septic, had renal failure, and then literally there's CTs a week apart.
Yes.
That show it developing in a week.
Yep.
And I have a case. Unfortunately, it's not my case, so I wouldn't feel comfortable showing it. It's someone who's not on this thing. I can ask them to show it, but literally develops in a week, and it's pretty amazing. And yeah, some articles say it's sepsis, and the question is it some sort of renal dysfunction, calcium imbalance due to sepsis, or to do some sort of renal injury from the sepsis? And I don't know.
Yeah.
This is a coolish case. I thought this was a cool case personally. So this was a young guy, 42-year-old, who had basically this long-standing history of dizziness, and he finally decided to get checked up, and they started with a CT of the inner ear, which didn't show anything. And he was so young, they kind of figured that, well, you know, it must just be nothing or some sort of vestibulocochlear thing, and he underwent a million tests. Finally, they got an MRI, and we could see on the MRI there's these areas of bright signal. And I am not a neuro guy, but if I can get this to go through, we can see that there's all these areas of bright signal on the ADC map, which also was bright on the diffusion. Anyways, he had, or dark on the diffusion, so he had these areas of, here you can see dark on the diffusion, these areas of infarct, and they're all over the place. So he got a chest CT, and
looking for a potential source of emboli, perhaps?
Yeah, for a potential source of emboli. And actually, I think he got an echo, and then they saw something, and so they went ahead and got a gated CT, and because they wouldn't have just gated this off the bat. And so we can see there's this large kind of villous-looking mass sitting in the atrium along the posterior wall, and it's interesting because I've seen a lot. So they took this out. I mean, this looks beautiful for a villus myxoma, and they took it out, and it sure enough was a myxoma, and it was not attached to. So I've seen a lot of left atrial myxomas. This is the first one I have to say I've seen that truly was not attached to the intratracheal septum. I know that they do occur. There's case reports. There's some in the left atrial appendage, but you know, really the vast majority really do. The right is a little different. The right can be more heterogeneous, but the left, really, the vast majority are in the region of the fossa ovalis on the intratracheal septum. But this was taken out, and this was a left atrial myxoma, and very villous. They described it just kind of falling apart even when they took it out. And this was the cause of his brain infarcts. So a very odd location for myxoma, and a somewhat interesting presentation. I think I showed another case where someone presented with a cold leg maybe last year from embolized myxoma. And then lastly, this I was going to get people's opinion on, and I never know, it's not a great study, I apologize, but I never know what to do with this. And we've seen this now, or at least I've seen this now a fair number of times, where someone who's relatively asymptomatic might have some minimal symptoms where they're so low risk they go ahead and get a calcium score. And I think people can see here that the coronary arteries are by no means normal. There's this, I don't want to call it aneurysmal, although it's technically aneurysmal. It's just more this diffuse ectasia, to use a better word, of the coronary artery. I mean, look how big this RCA gets, of the coronaries. And you know, I never want to call this Takayasu's because it's not really a focal aneurysm. It's just this diffuse abnormality. No other disease really elsewhere in the thorax. The aorta is normal. Pulmonary arteries are normal. And I don't know if any of the guys who do cardiac imaging have seen this, and if so, what do they attribute it to? I mean, I usually just read it out as diffuse dilation ectasia or multifocal dilation ectasia of the coronary arteries without any real clear etiology. So just, and again, this is not the first time I've seen. I just brought it up because it's been something I've seen once or twice a year now.
Don't know.
How patient, Seth?
He's like 48, born in this country. And the people I've seen it in, again, they're not like older patients. It's not, I mean, he does have some, maybe he was 52. I think he was 52 or somewhere a little, but so he has some mild atherosclerosis, not normal, but clearly not, you know, we see atherosclerotic aneurysms and there's usually diffuse atherosclerosis, and he does not have that.
How about hypertension?
No, I've not seen hypertension do that to coronaries before. And he was, I don't think he might have been hypertensive, but I don't think he was really hypertensive. Anyways, if anyone else has seen cases or knows of a cause, let me know, because I now have a whole collection of these. And
yeah, I don't know of a cause. I mean, I agree they're more ectatic than they should be, but
yeah,
it's not, you know, if it's old Kawasaki's disease, it's probably stable by this point.
Yeah, and I kind of invoked the possibility of
how about the same mechanism that you have with aorta when you have atherosclerosis-induced inflammation? Could you have the same sort of mechanisms to the coronary arteries? Because you do have some calcifications, and those, you know, peripheral low attenuation things, they look like they could be just the soft tissue plaques.
He has disease. He definitely has disease, and as we know, you get positive remodeling and some mild and some dilation of the coronaries, but this really gets quite big, and it could be theoretically atherosclerotic, and it could be inflammatory. I'm not saying it's not. I just have seen a fair amount of coronary aneurysms due to atherosclerosis, and there's usually extensive disease, and there's more. I don't know. I just haven't, like, even these obtuse marginals are just dramatically. I've never seen obtuse marginals this big. Anyways, it's just.
Are there any Marfan syndromes or Marfan-like syndromes to consider?
So yeah, I looked at all that stuff, and he didn't have, his aorta was normal. He didn't have any history of anything. He was just he was actually a friend of one of our cardiologists, and who's a proponent of cardiac CT. He was a young guy who was having some very, very, very atypical chest pain. I mean, stuff that was like sitting down on his couch, he would get chest pain kind of thing. And so they're like, oh, let's just get a coronary CT to rule stuff, just to make sure everything's good. And 99% of the time in those cases they are, but this time, I mean, they're not going to do anything with it. But but the answer is yes, you can have coronary ectasia with Marfan's, but he didn't have that.
And what's the Marfan's-like thing that's worse? It's got a Dutch name.
Ehlers-Danlos?
No.
I don't even know where
Louis Dietz. Yeah, Louis Dietz.
Oh, Louis Dietz.
Does that have a coronary set of manifestations?
I don't know.
No idea. But they usually present in childhood with aortic issues.
There are 3 different types, and they have different manifestations.
Okay.
Yeah, I don't know. But it's just odd. But thanks for the input. I'll send that one along. That's all I have for today.
All right, thanks, Seth. Mariella, you're on. Do you want to show some cases?
Yes, please. And Dr. Kligerman, please do not leave. I really need your input. I'll send you an email.
Well, yeah, no, I haven't had a chance to look at it, but Travis could probably
help. Well, you look at them right now. So let me show this to everyone. All right, so you and probably Travis and the rest of our crowd, please help me out. Well, it's more of the, clarification in my own education, because this study has been done in 2015, and I just somehow get back to that through discussion with the fellows and the residents, and got into sort of controversial issue. So before I show you the images, this is 49-year-old female who presented to our institution last year in, I believe, July. Yes, well, actually October, right there. And she did have some atypical chest pain. She did not have that characteristic troponin elevation. She does have some risk factors, specifically hyperlipidemia, and for whatever reason, she started smoking about a year ago. So they did CAT in outside hospital, and that was negative as per report. And then after this MR, and after the fact that she continued to have this chest pain that really was not alleviated with anything, they repeated the CAT, and they said that there was 80% left main ostial narrowing, which in retrospect was also there on the first CAT, but for whatever reason was not reported. So now, with that, let me show you the perfusion images. So the image on your left, which is this one, is going to be the stress, I believe. Let me click on it and just make sure. Well, okay. Yes, so this one is the stress, the left one is the stress, and the right one on a rest. And if I go through those, so these are both perfusion and the 4 chambers. There is apparent perfusion defect, and unfortunately they are not really linked, but you can see there's sort of all over the submetacardial regions perfusion defect, and that's for whatever reason gets even worse on the rest, but not on the stress. So in other words, we do have perfusion defects, multifocal, which gets worse on the rest. So, and the contractility was normal, and I can show you just, for instance, 3 chamber, just to confirm that. EF was completely normal, and there wasn't any gadolinium enhancement per se. I'll show you just for matter of discussion. Well, gadolinium enhancement. So there wasn't really there wasn't contractility abnormality, but there was that diffuse subendocardial perfusion defect, which got worse on the rest, but not on a stress. So we looked at everything, and then I discussed it with my mentor, John Greasert from VCU, and he said, just, Mariana, it sounds like syndrome X with microvascular dysfunction. But then the cardiologist came back to me and they said, well, no, it doesn't really go along with our CAT. We think it's a main vessel disease. So I'm thinking that it might be just 2 abnormalities, but because I cannot put together how is it possible to have this much of subendocardial perfusion defect and not having this much of any, well, in contractility abnormality, just for instance, or delayed enhancement is okay, so she doesn't have to have delayed enhancement, but just discrepancy between absence of contractility abnormalities and that diffuse subendocardial perfusion defect doesn't really go along in my head for major vessel disease.
What about, I mean, we never really see the RCA territory distribution. Do you have short axis?
I do. Yeah, I do. Let me bring it up. So you want the perfusion?
Because that could still, I mean, everything we're seeing on what you're showing here could be left main.
Yeah, on the CAT, the RCA was completely clean. So the RCA was completely clean. Then having said that, I didn't really see the images, but that's what they've told me. So this is...
Oh, so, yeah, wow, okay.
Yeah, so it's everywhere. It's literally everywhere. And it's worse with the rest, and it's better with the stress.
What did you say the cath showed?
80% stenosis, ostial stenosis of the left main. That's what they told me.
Do you guys do a lot of perfusion? Because what about this could be partially at least a Gibbs artifact, and it is pretty pronounced.
Yeah, well, it's usually not the Gibbs artifact that we have in our institution. It's little more than just an artifact, especially on this one.
Yeah, no, I'm just trying to figure out, because it looks like on the 4 chamber that there's even a little low attenuation in the portion of the left atrium you're showing. Which
that's
is kind
another thing. Yeah, that's possibly as well. But it just doesn't go along. And contractility was completely normal. Well, the question to you, because I haven't seen obviously so many cases. I read about syndrome X before, and if this is the case, then this is my first case. Travis, you've seen a lot. Dr. Kligerman, I'm sure you've seen more than.
No, I've not. I mean, we don't do stressed imaging here, which is great. So I don't have enough. I mean, I've seen subendocardial hypoperfusion, but not to this degree, and I don't have a lot, since I don't do the stress, I have very little to compare to. I don't know, it's odd. I mean, it sure looks like multi-vessel disease, but you're saying the cath only showed left main. I mean, it's not going to be.
Yes, and what was bizarre, there's no contractility abnormality, and obviously no delayed enhancement here. It was normal.
Yeah, well, you can have. I mean, you can have left main disease, and I mean, the lack of enhancement in the normal contractility doesn't bother me. I mean, it could just be ischemic myocardium and still work quite well. You know, you're only going to see delayed enhancements, and I mean, usually with that degree of ischemia, you will see some decrease, but we don't know what her baseline was. But I have seen cases of people with basically normal MRIs who, other than a perfusion abnormality, have a normal MRI, and then they go to cath and have bad disease in that segment. So that portion doesn't bother me. What's interesting is the RCA involvement without a normal without a normal with a normal cath there. But God, I don't know. I mean, I agree with Travis. It is very, very pronounced, but you almost wonder if it's an artifact, but it doesn't probably sound.
I'm going to talk to one more person who just a recent addition to our faculty in cardiology. She's one of the experts who writes all this, standard criteria for Syndrome X, and I'll let you know, because this case is really unclear for me, and I'm not sure if I completely can agree with cardiology. It's just a little odd. Let you know. All right. So
Yeah,
and the next.
Yeah, this is nice lipomatous hypertrophy. That's pretty.
Well, for that, yes. All right. So, let me show you just a case, probably more for the students, just to torture them a little bit once in a while. And let me bring it to double windows again. Here we go. So we will do a lot. Well, that's not what I want. Okay, so right there and right there. Oops. How do I get back? No. Okay. How do I?
Hit Command R.
I lost you, Howard. Where do I go? Oops. All right. So let's start all over again. Well, okay. Well, anyway, the main abnormality is actually on the frontal view. So if you look in the frontal view, we have this opacity, which is sort of partially defined. The medial wall is seen, but then you're kind of losing the inferior wall, and it looks like it has a broad contact with the chest wall laterally. And if people and residents are astute, then they will see that this is associated with distraction of the posterior right rib right there. You see the portion of the posterior rib, but then the lateral is gone. And that was due to, let me change it. That was due to metastatic lesion related to melanoma. That was a case of metastatic melanoma, the distraction of the rib and creating this extra parenchymal opacity and missing portion of the rib on the frontal view. And these are the cases that I have today.
Mariana, on that radiograph also, you can see the lateral displacement of a little fat stripe in the chest wall on the right, on the radiograph. It's kind of nice as well, showing the chest wall involvement laterally.
Oh, you mean right there?
Yeah,
Yes. Yeah. I didn't notice it the first time. Yeah, very good. Thank you.
Sure.
Thank you, Jeff.
All right, thanks for sharing. Howard or David?
I have
a couple. David, you go first.
All righty.
When people see a chest radiograph,
We do.
This is an 11-year-old. I was just shown this case this morning. This person arrived at the Children's Hospital, had fever and cough, is from Persia, and there was concern about tuberculosis with cavitary lesions over here on the left. So that was the chest radiographic dilemma, and this led to CT.
Before you show the CT, can you just zoom up a bit, just for fun?
Zoom up.
Yeah, just make it a bit bigger. Can we see a left main bronchus or left bronchial tree?
Well, we have these air-filled tubes here. We have something that seems to be going out like this. Here is this one is the trachea. Do you think there's a carina here?
Can't tell.
Yeah, it's not very convincing.
Yeah, the other question is too, is the arch left-sided or right-sided, I guess? I don't see one on the right here.
It descends on the left, though, so it's probably lateral to the spine. That looks like the aorta descending there.
Okay. And this
Yeah,
is
and the ribs are really small. The hemithorax is small, so I always think of congenital conditions and wonder if there's any lung there, etc., etc.
Okay. What about the level of the diaphragm, though?
Yeah, it's not that high.
Right.
Is there pleural fluid? Is there pleural thickening? Is there just fat there? Yeah, there's two tubes up there near the trachea. One's the trachea and one isn't, and I'm not quite sure what that is.
Okay.
So, yeah, help us.
So here we here we have, doesn't that look like a left main bronchus? The answer, no.
Nope.
No, it doesn't. So there is no left bronchus here.
Okay,
So,
now we've seen some things.
Okay, so let's go back to the trachea. Trachea comes down. This is esophagus, which is dilated.
Okay.
And then we get into this air collection here, which turns out to be right lung, which is coming across into the left hemithorax. There's no left pulmonary artery, just a right pulmonary artery. And there's no trachea goes smoothly into this right bronchus here. We have an upper lobe, and then a bronchus intermedius on down. So there's no left bronchus, and there's no pulmonary artery. The aorta is displaced way off to the left here. And this is all right lung that is coming across posteriorly. So this is a very attenuated posterior mediastinum. The posterior junction line is way over here. Right lung tucking in not only anteriorly to the left, but posteriorly dramatically as well. It looks like pretty normal anatomy on the right. There's some little funkiness of vessels here. We seem to have we do have a brachycephalic vein here, but we have a small, I think, left superior vena cava that comes down. Here it's out here, so maybe I can connect that up here. So it goes up here, and then ultimately comes into the mediastinum. I think goes to coronary sinus down here. It's a little indistinct down there. So we also have a right SVC, so probably paired SVCs.
Is that just a big superior intercostal draining into a hemiazygos? It looks like it does.
That's a good point. It does have a hemiazygos continuation connection. So let me make that. Yeah.
Yeah.
So here's here to join that, but it also seems to
see it hooks up right there. That
right, but then it continues in here.
Ah, I see.
So, yeah. So a few different spokes here, but this is you know, really an absence of an aplasia of the left lung. I think, guys, accept that?
Yeah, an agenesis.
Agenesis?
Yeah, there's no bronchial stuff.
That's one of the books of the Bible.
But it's interesting that that little bit of left lung, I mean right lung, goes in front of the spine. That's a little unusual.
Yeah, and it drags the aorta with it.
Yeah.
So the aorta is dragged away from its medial position here.
Cool.
Okay.
Really interesting. Well, and it's obviously a different entity than proximal interruption of the pulmonary artery because that's almost always associated with the right arch. That was what I was getting at on the chest radiograph too. That you have a left-sided arch.
The other thing in those situations is you actually, I mean, you have lung there, and this person doesn't have any lung. And hypoplasia you might have a start of a pulmonary artery or a bronchus on that side. That would be hypoplasia, but the absence here is aplasia, or they're calling it agenesis.
So do you consider that horseshoe lung or just herniation of the right lung?
Because horseshoe lung is supposed to have an isthmus between two lungs, right? So technically it's herniation. Is that right?
I think so, yeah.
Yeah,
I'm glad you guys are bringing up all this bad technology, because when you have scimitar syndrome and you have so-called horseshoe lung, it's not horseshoe lung, because you don't have actual fusion of lung parenchyma. You have a piece of the right lung that has a course similar to this, goes way over into the left hemithorax, but it's separated by 4 pleural layers from the other lung. The lung tissue is not connected the way renal tissue is connected when you have a horseshoe kidney. So this would not be horseshoe. And it's not herniation either, because the barrier is there. You know, the mediastinum is just very attenuated posteriorly, and there's actually mediastinal tissue out here probably. Now, I've not done surgery on this patient, so I can't say that for sure.
So I'll just say extension.
Yeah, it's really just extension of the right lung into the left hemithorax. It's being sucked back there wherever it can go. And the anterior junction line that's not here because we don't have the other side is being pulled this direction. So we have this profound mediastinal rotation. The right lung's being dragged along with it.
What's the difference between aplasia and agenesis?
I think those are
synonymous.
So agenesis means there's no bronchial tissue at all. So there's no foregut bud, whereas aplasia means there's usually a little bud or stump of a bronchus, but there's no parenchyma. So it's it's an aborted lung versus no lung.
Okay, very good. That's helpful. So Angelisa was here over my shoulder here looking at this case. She's the one who asked me to look at it, and thanks for your input on that. She's trying to perfect her reporting of this case. Okay.
Just out of curiosity, are there any other congenital anomalies in this child?
Not that people are aware of, and I didn't see anything else. I mean, the right lung looks okay. There's that left sided SVC thing with some funny connections, but that's not so uncommon. And the upper abdominal situs here seems to be okay. 2 kidneys, spleen on the right side. And that child, I think, was not that symptomatic leading up to this, but I don't have history on this person.
The separation of the esophagus from the aorta by that right-sided lung tissue is really interesting.
Yeah. So I've seen people, you know, with bad COPD, for instance, who have a very attenuated posterior mediastinum, and their esophagus is sometimes floating as an island. It's got these, you know, the pleura goes up from around the spine. Then you come to esophagus as a little nodule, and then there's a thin tissue again that goes up to the heart. So you can get a very attenuated posterior mediastinum in somebody who's hyperinflated, say with COPD. They actually get a posterior junction line way down here at this level, so a lower thoracic posterior junction line rather than the usual upper thoracic posterior junction line that we're familiar with. So that mediastinum can be very attenuated here and form an isthmus with the esophagus floating in it. In this person, the esophagus is actually in front of the attenuated tissue. So here's the esophagus here, and the attenuated tissue must be going around like this. Okay. So I enjoyed that case. I thought that was a fun case.
Yeah, we did too.
So this person is I think a 46-year-old, 40-some-year-old man who has psychiatric problems and is not very conforming with his medication. He had a diagnosis of Hodgkin's lymphoma, and he did have a big right hilar mass as part of his Hodgkin's lymphoma. So at this point, he's had chemotherapy, and his hilar mass is actually resolving. So this is somewhat smaller than it was before. But then he began to come up with some lung nodules. You can faintly see something behind the heart here and maybe down here. So there were new lung nodules on the left that warranted a CT scan. And the concern was with his chemotherapy that this was fungal infection. So here we have his residual Hodgkin's. And then we come to some lower lobe nodules. Here's one of the things we were maybe seeing on our chest radiograph, and several others down here, and then a very nice one here in the lingula right along the fissure. So it's a little unusual distribution for fungal nodules. They don't like lower lobes in particular. The lingular lesion would be fine for fungus. This one's very peripheral. You wonder about something embolic there.
David,
but these
they also have air bronchograms, which would also be unusual for fungus.
Yeah, it makes you think about lymphoma, doesn't it?
Yes.
But his lymphoma was getting better elsewhere, so people weren't happy with that. And so they ultimately did a VATS resection of this lung nodule, and they cultured it for everything. And nothing grew in culture, and the PCR for fungus was negative. PCR was negative for tuberculosis and for atypical mycobacteria and for bacteria. So there was no diagnosis. And then they sent the tissue to an outside lab, and they did PCR on it, and they detected syphilis.
Wow.
So these are gammas. These are syphilitic lung nodules. They had stopped his, once they got negative fungal results, they stopped his posaconazole, and he was being treated. It turns out then that he developed uveitis, and the ophthalmologist thought that was consistent with syphilis, secondary syphilis. He had a rash on his palms, and that was considered secondary syphilis. So this is syphilis, and he's considered to have neurosyphilis involving his eyes, and lung syphilis here, his lungs. He was treated with antibiotics, and these lung nodules went away. So, syphilitic lung nodules. So I've heard of syphilitic tumors, and they're called gummas. This is the first time I've ever had a gumma on my screen. So you might want to ask, if you've been in this business so long, how gumma? But the answer is just fate. So now finally I got a gumma.
This is the case of the year.
That's pretty cool.
Okay.
That's pretty cool. Can't beat that one.
Those are the two I have.
All right, thanks, David. All right, Howard.
Okay, no gummas here, so whatever I show you isn't that. For this person, I'm actually going to bring up on the right side the clinical presentation just to make things go along as well. You can see this person had a diagnosis of a connective tissue disorder, particularly rheumatoid, back in 1995. So you see she had a positive AMNA, but she's got a rheumatoid factor and anti-CCP. And the combination, of course, just of the RF and the anti-CCP would certainly point towards rheumatoid arthritis. And so that's back then. So let me show you a radiograph from 15, and clearly she has hyper-inflated lungs. So I'll bring up the thin cuts from June of last year, and you will see, I'll get to the nodules in a moment, but she has substantial hyperinflation. It's so severe that it's really hard to actually find a pattern, except maybe down here that one would describe as mosaic attenuation. And in terms of the more central airways, they're not particularly dilated, maybe there. Actually, about here, I think I can make it look like some mosaic attenuation. Yeah, I can see it now, sorry. So certainly these findings are very consistent with constrictive bronchiolitis as a cause of that, and we know that association with rheumatoid. You can see there that she had a biopsy in August of that year, and you can see that there are findings of constrictive bronchiolitis. You can see the description of it, and quite a nice description of that. Let's see if I can bring up the, and you can see here a description of a dropout of airways. So if the pathologist knows what to look for and they look for airways, they might recognize that where there should be airways in the pulmonary lobule, they're not there. And of course, they may see other things too. So they may see findings of follicular bronchiolitis. But anyhow, the findings are very much consistent with constrictive bronchiolitis. And then, yes, she did develop these other nodules that you can see here. So here's one that's cavitated, one in the apical right lung that is not, but this one is cavitated. And she did have a CT-guided biopsy of one of these that yielded aspergillus. And because it didn't go away eventually, they decided to take that out. And let's see if I've got that path right there. So here's the CT-guided biopsy. And here you can see they took that out. So I think they blamed the aspergillus that subsequently developed in her due to her immunosuppressive therapy for her rheumatoid arthritis. So that was a complication of that. But really nice findings of constrictive bronchiolitis, and then aspergillus is a complication of therapy.
So Howard, you know, the CT scan here for the air trapping, when it's this uniform and widespread, you know, you don't get the patchiness, the mosaic pattern that makes it easy. But the thing that's still operating here that's very suggestive is down in the bases in particular is the dropout of vessels in those most dependent regions down there. You just have these regions here with almost no vessels visible, like down in that right base. So when you see that, that helps me recognize that there indeed is air trapping, even when the uniformity here keeps me from seeing a nice mosaic pattern.
Okay, yeah. And the thing that she doesn't have that sometimes a clue is that these segmental bronchi are not particularly dilated, which one can sometimes see, and sometimes a conspicuous finding with severe constrictive bronchiolitis. but not really in this person, I don't think. Yeah. Okay. The next one is really interesting. I want to see if I can actually, I wish I had a chest radiograph, so I don't know if this will work or not, but let me try and make a chest radiograph out of this. So I'm just going to quickly do this and make it like that. And this may not work very nicely because these are not thin cuts, but a chest radiograph is going to look something like that. So we're going to have someone that comes in with an acute illness, and we're going to have bilateral, patchy, but strikingly peripheral opacities in the lungs that look like that. And to take that away and look at the CT, it'll look like this. Well, let me bring in this one. So she had a CTPA actually for her symptoms. And let me just do this. She does not have PE, but she's got these subpleural, patchy, consolidative opacities in both lungs. And her presentation was not that of an acute febrile illness, so it raises the differential of non-infectious lung consolidation. And then you're off to the races if you get some more information and you're lucky. So here it turns out that she has eosinophilia. And you can see there that they did a BAL, and the level of eosinophilia there is 55%. So eosinophilic pneumonia, but why? So it turns out that she has a surrogate pregnancy, but someone was smart and asked what drug she's getting, and she's getting an intramuscular progesterone preparation, and I can't remember exactly why she's getting progesterone, but she is. So then you go to Google and you find some case reports of this ascribed to progesterone, and then it turns out they're not quite sure. It's not necessarily the progesterone, but they speculate that maybe there's something in the preparation that is the antigen that causes the eosinophilia, so sesame oil or benzyl alcohol. So these guys said we published the 6th published case report of eosinophilic pneumonia. So she was getting progesterone, and that was stopped, and they advised maybe giving it with some other preparation, like maybe vaginal, I think. But there you go, very nice classic findings consistent with acute eosinophilic pneumonia. In this case, not idiopathic, but drug-related, or thought to be drug-related like that. So really nice case. Alrighty, let's see. I just want to show you this one picture. Maybe you've all seen this before. This is not that exciting, but I saw this new device the other day, and it was not a hardware, which I've seen before, so our folks are starting to use another intracorporeal left ventricular assist device other than a hardware. And this happens to be a new one, relatively new, called a HeartMate 3. So that's what a HeartMate 3 intracorporeal LVAD looks like. Just pretty straightforward. Okay, Jeff.
All right, thanks. I think the HeartMate 3 might be part of a trial, because I think here they're randomized to a 3 or a 2.
Okay.
All right.
Okay. Not approved yet.
All right. So I got a nice case sent to me right before a conference from the folks in Augusta. I just have some JPEGs in a movie that I had to quickly convert to a Mac format, but I will send along a better copy of the movie. So this was a trauma motor vehicle crash, and you can see on the initial radiograph, patients intubated, small volumes, underinflated, but not much going on. This is a subsequent radiograph here, which shows a lucency here in the right lower chest here. This patient went to the operating room for abdominal surgery and had a bunch of injuries, and they noticed a defect in the diaphragm at the time. And I'm going to play this movie. You'll notice the resolution's off because I had to rapidly convert this, but it'll still show the findings. And so I'll scroll through it once it cycles. But you'll notice there's a lateral intercostal hernia here. I'll go back and can you guys see this at all?
Yep, good.
Good. My screen's behaving today. But if we go back, if I just scroll right there, you see in between the ribs there. And in the note that was sent along, they said that they originally thought this was maybe a chronic hernia, but they noticed sort of a T-shaped tear in the diaphragm. You can see right here, there's a defect here in the diaphragm as well. So unusual manifestation. It's kind of a nice example of this. I don't think I've seen this. I've seen it after like a thoracotomy or a lung transplant, something like that, but not not traumatic like that. So really nice case from the folks in Augusta. And I'll convert the images to a format that people can use. Okay, I have two congenital cases I'll share, and then a trauma case. This is just a classic, but just a really pretty case of a aortic coarctation. Unfortunately, I don't have a chest radiograph, but you can see there's a left aortic arch, there's an aberrant subclavian, but rather large collateral vessels here in the mediastinum. And you'll see right here there's a coarctation in the usual location at the ligament. You can see on the multiplanar reformat, there it is. So this child would probably, he's 4 years old, would probably have maybe a little bit of rib notching. I'm going to see if I can do what Howard did, and make a pseudo radiograph, maybe out here, but just a pretty classic example.
So Jeff?
Yes.
Jeff, was the coarct in front of or after that aberrant right subclavian?
Good point. It's beyond it. There's the aberrant subclavian, there's the coarct beyond it.
Okay, because if it were a little more proximal, you could have unilateral rib notching.
Exactly, but you can see these these collateral vessels are actually quite large on both sides here. But that's a very good point. And I'll show it on this the axial for SSFPs. You can see the right ventricle is dilated here, and as I come up, you'll notice there is right here an abnormal connection between the left atrium and the right atrium here. So this is a sinus venosus type ASD. And if I go up a little higher, you can see the anomalous pulmonary venous drainage here into the SVC. And my colleague Chris Francois made some nice, like a little montage here showing that you can see there's the connection right there. And then you see the anomalous drainage coming in. So this is just a nice example. So this was undiagnosed cause of his pulmonary hypertension. And his shunt was actually a 3-to-1 ratio. So it was a pretty sizable shunt. So he's going to get fixed that. But I'll send along the whole MR, and I'll clean up the radiograph before I do that. Sorry about that. This is a nice teaching case, and unfortunate. This was a young man who was a drunk driver, crashed his car. You can see the mediastinum is abnormal. There's a bilateral paratracheal stripe thickening. There's biapical caps here. And then if you notice carefully, if I change the window, you'll see the spine here is not aligned with the spine here. And there's also probably some abnormalities down here. So we've got a very severe spine injury. This is a lateral fracture dislocation of the thoracic spine. And I'll put it up on a coronal. So this is a complete cord transection, but you can see really bad here. So there's lateral displacement and step off there, but with paraspinal hematoma and biapical cap from the extrapleural blood up there. So really bad trauma.
Terrible injury.
And you said spine. You said he transected his cord.
Yes, at T4 level. Now this is an impressive case for many reasons. This was a young man who was 26-year-old who was stabbed allegedly by his girlfriend. I don't know any other story there. This is his radiograph, and you'll see there's a huge pneumothorax. There is pneumomediastinum and subacute gas. He was subsequently intubated, and they had a lot of trouble managing his airway. This is a neck CT. I believe this is the one from the outside. Yes, so they haven't repaired him yet. You can see there's a bandage on here, but you can see there's a lot of gas in the neck, and we see right here an anterior tracheal defect. I'll blow up for you. So you see the defect here, and then if I change windows, you'll also notice there's a posterior membrane defect on the right of them, and then that's the neck CT, and then on his chest CT. So then he took him to the operating room, and they did a neck exploration. You can see the drain. They did a repair of the cartilage's anterior injury. But what's really cool is you can see better to advantage now the posterior injury right here. So it was a through and through knife into the mediastinum, and then it follows into the pleural space. And then you can follow the knife tract right here into the right upper lobe. So it went from the sort of the suprasternal notch through the mediastinum, missed every vessel, went through the trachea into the pleural mediastinum, into the pleural space, and in here and stopped at the chest wall. So we figured out it's about at least a 10-centimeter knife that went in, and she was a very good shot because she missed every vital structure except his trachea. So the treatment for this was actually the thoracic surgeons decided to put a stent across this posterior injury because it was membranous, and so that's where he lies there. But we don't see too much penetrating trauma in Madison, so this was kind of an exciting case. But I thought it was kind of neat because you can actually see the course of the blade, and then you see this giant fistula here.
So you think she probably just wanted to scare him? She didn't really want to injure him, so that's why she didn't know away.
No, she wanted to injure him, but she wanted him to survive so that he could suffer more.
That's right.
Yeah, well, it looks like he's going to be okay for now. So anyway, all right, those are my cases. Anybody else have anything before we wrap up?
Mariana, I was just thinking about your case. Are they sure that there was 2 discordant caths? I mean,
Yes.
if she really had whatever the chronic microvascular disease, I mean, is it possible that she in fact did have a normal cath and that the ostial narrowing was an overread?
That's what I'm thinking. That's what I'm thinking, and that was the first question that I asked. How is it possible in just a matter of 2 months to get 80% stenosis? So,
well, that can happen with an acute plaque rupture. It's more usually you don't have disease with syndrome X or chronic microvascular disease. And I was just, and did she have? I mean, did she have ST elevation? I mean, she should have an abnormal.
Well, she did not have ST elevation. That's another.
Even on a stress imaging, she never had any ECG.
Well, let me go back and review the stripe, and I would be able to.
That's one thing you should still see ECG abnormality, EKG abnormalities, even with chronic microvascular disease.
I think they told me that there were some repolarization issues, but I'll go back and double check, and I'll let you know.
It's just interesting because I haven't seen the case, but I know the imaging would fit very well.
Yes.
But if you told me there wasn't left main disease, I would say, but to have left main and then it's just odd. I'd wonder if.
Yes, yeah. Unfortunately, in our institution, they sometimes put the stents, maybe not necessarily for a very obvious reason. And but I'll talk. Well, first of all, I'll go back and look at EKG, and then second, I will get a second opinion from the lady who is an expert in that disease, and I'll let you know. Thank you.
Yeah, she's the right demographic for it. That's sure. All right.
That's definitely. Thank you.
All right.
All right. Thanks everybody. See you next week.
Thank you. Later. Bye.